think for the most part, STIs sort of encompass all people, including people with HIV. So there are a few things that you'll learn that are related to our group. I'd like to acknowledge, first of all, that we are gathered this evening here on unceded Coast Salish territory. And I have a few housekeeping notes that I'd like just to remind everyone. We're a small group tonight, so if you are speaking to the people beside you, you might be interrupting the people who are presenting. So try and keep it to a minimum if you can while they're presenting. If everybody could please take a minute and make sure that your cell phone is turned off, or put it on vibrate, just out of respect for the people that are around you and for the presenters. We are very pleased to announce that we are also live on webinar tonight. With our webinars reaching our HIV positive members and friends across the province and the country. So welcome to all of those who are joining us online. It's great to have you with us. We are also being recorded tonight, so this event we'd like to have it appear on our website at some point. So the camera's going to basically remain focused on the presenters, and so you don't have to really worry about your confidentiality. We're going to try and make sure that the presenters can do their presentation, and then we'll have questions at the end. So if you have any questions or comments, please try and hold them until the end. So I just wanted to tell you a little bit about our presentation tonight. Sexually transmitted infections, as you know, are a serious concern. Rates are on the rise right now in British Columbia, across the country, including things like chlamydia, gonorrhea. There's a really big increase in syphilis infections that you've probably heard about recently. Tonight we're going to have guest presenters from the BC Centre for Disease Control. Our guest presenters are Jason Wong and Troy Brennan. They are doctors with the BC CDC. They're going to give us all reasons why the rise to tell us a little bit about why the rise of syphilis cases in the community matters to gay people and how you can help address this problem. You're going to learn a little bit about screening, treatment, vaccinations for HPV, which is one of the most prevalent STIs worldwide. That is a serious infection that actually is related to various cancers. So it's quite serious. After their presentation, Adam Rodman from Positive Living is going to just give us a little update on something called the Syphilis Project, and then we will open the floor to questions. All right, so thank you again for coming. I'm going to, at this time, announce our first presenters, Dr. Jason Wong and Dr. Troy Brennan from the BC Centre for Disease Control. If you can all come up and we can sort of start the presentation.
So thank you, Brandon, so much for the organizing this event, and thank you to Positive Living for inviting Troy and I to speak about some of the work that we do around STI prevention. Let me just hold it. Feels like it's going to fall. Around STI prevention, treatment, and control. So Troy and I actually work for one of the 4 divisions of BC Centre for Disease Control called Clinical Prevention Services. And one of the things that I particularly like about this division that we're in is it's an integration of clinical services with public health. And so what I wanted to do was model our presentation around that and try to describe some of the ways in which public health and clinical services are integrated together. And so maybe just to kind of let you know like our positions in BCCDC. So I work currently as a public health physician. My official title is physician epidemiologist. And Troy works as the medical lead for STI HIV. And so we work very frequently together, looking at how we can blend the 2 pieces together to look at STI prevention and control. So first I thought I would begin with some broad definitions of what is an STI. So an STI is basically any infection that's transmitted through any type of sexual contact, which usually means vaginal sex, and anal sex, and oral sex. But one of the things that I wanted to highlight is that some of the STIs can actually be transmitted through other means, and not exclusively through sexual contact. So some example of this is like hepatitis A, which is primarily spread through drinking or eating contaminated food or water, but can also be spread through some sexual activities like rimming. And hepatitis C and HPV are some other ones And Troy will talk a little bit more about HPV later, so I won't steal his thunder here. So among all the different types of STIs, there are a number that are reportable by law. And so under the Public Health Act, under the community regulations, there are 7 STIs that are reportable by law. That means that if a lab diagnoses it or a physician diagnoses it, it is reportable to public health, and I take that information in order to monitor those STIs in BC. And so the most common ones of these are chlamydia, gonorrhea, syphilis, and HIV. Chancroid and granuloma inguinale is also reportable, but those are really basically non-existent in Canada. They're really much more common in the developing world. The last one is herpes simplex, or the one that causes genital herpes, which is currently reportable only when it's diagnosed by labs. So if a physician diagnoses genital herpes, it's not reportable to public health. But this is actually being slated to be removed off the regulations. So I often get asked, why do we need to monitor for STIs? And I basically kind of bring this down to 3 main reasons. The first is the communicability of STIs and the potential for spread and for the potential for an outbreak. And so for that reason, we do want to monitor what's happening around the community and what's happening around the community and what we can possibly do to prevent that. The second is a severity of disease, so diseases that cause more complications or more problems for individuals are diseases that we are more likely to monitor for. And the third is the one that I think is the most important as a public health physician, is preventability. So what we really want to get at is how can we prevent an outbreak? How can we prevent people from having severe complications from an STI? So with that in mind, I'm just going to describe some of the epidemiology of STIs. And what we really have good data for is those reportable STIs because they are reportable by law. And so we have very good data about how many of these cases we're seeing in BC. So I summarized the top 3 right here. So the first is chlamydia, which is the most common reportable infection in British Columbia. So last year we had about 14,000 chlamydia cases reported, so quite a lot. In general, the trend has just been upwards it's actually much more than just the last 8 years. But chlamydia affects generally women more than men, and it's usually spread, so it's mostly heterosexual contacts that we've seen the chlamydia infections. Gonorrhea has also been increasing. Last year we had quite a large spike in gonorrhea cases. There were about a 75% increase in gonorrhea reported. And gonorrhea, contrary to chlamydia, affects more men than women. And a lot of this, I think, is because of the increased burden among gay men. And we've also seen a lot of extragenital gonorrhea. So in other words, gonorrhea in the pharynx, or the throat, as well as the rectum. So those are 2 areas in which we have seen about a 3-fold increase in gonorrhea from 2014 to 2015. So these are a big concern that we have about with gonorrhea, particularly with antimicrobial resistance, which I think you pointed out, Brandon, in the sheets on your tables. But fortunately, we've actually seen a decline in resistant gonorrhea. So that's actually one of the good news stories around gonorrhea. And we think this is because we've changed our treatment in order to cure more people from gonorrhea and to prevent transmission. The third one on this slide is HIV. And HIV has generally been decreasing for about the last, it's only been reportable for about 15 years, so I really only have data for that. But for the last 15 years, it's been decreasing and or plateauing as it has been the last 3 years. So one of the subtypes of chlamydia is called lymphogranuloma venereum, or LGV. And this is technically called a serovar of chlamydia, which can cause very severe inguinal lymph node enlargement or lymphadenopathy, or proctitis, which is like rectal symptoms. And so LGV really didn't exist in Canada until about 2003. Since then, we've seen an increase of LGV since then. Last year, we had 45 cases of LGV reported, which is the highest number that we've ever had. And Troy and I are working hard to try to figure out what's going on around why we may be seeing this increase. But in terms of those 45 cases, over 95% of them were among gay, bisexual men who had sex with men, and over 2/3 of them were among people who were living with HIV. So the last that Brandon already made some allusion to is syphilis. And so syphilis was actually, there was a time not too long ago when there's only 14 or 15 cases of syphilis reported in the province of British Columbia. But last year we had 762 cases of syphilis reported. which is a 40% increase from the year before, 2014. And of these 762 cases, about 85% were among gay, bisexual, and other men who have sex with men, and over half of that subgroup were also co-infected with HIV. I'm just going to break this down a little bit further because I think a lot of people may be interested in this. But most of the syphilis is in Vancouver, in the Vancouver coastal area, but we have seen increases in all 5 regional health authorities in British Columbia and really in many jurisdictions around the world. In terms of age groups, the highest rates are among young people, 20 to 29-year-old, which is the green line and the blue line, have really steep rates of increases. So from 2014 to 2015, that slope is quite a bit steeper. And so that does give us some concerns that people may be getting infected with syphilis at younger and younger ages. So with that in mind, I just wanted to talk a bit more about the clinical pieces of syphilis. So syphilis is caused by a bacteria called Treponema pallidum, and it goes through multiple stages, starting with the primary, secondary, and then the latent stages. And the parts that I've underlined are the infectious stages. So primary, secondary, and early latent are the infectious stages of syphilis, whereas the late latent and tertiary stages of syphilis are non-infectious. Up to a third of people who don't get treatment for syphilis will develop complications, and syphilis can affect really any organ of the body, such as the brain, the eyes, the heart. People living with HIV may have presentations that are a bit more unusual, and people living with HIV may also are more likely to have complications of syphilis, such as having infection in the brain or in the heart. On the flip side, syphilis infection can enhance the transmission or the susceptibility to HIV. So I'm just going to go through these by the stages. So the primary syphilis is usually characterized by an ulcer at the site where the syphilis bug has been seeded. But this ulcer is it's usually painless. And so a lot of people don't notice it, or they don't pay too much attention to it. And sometimes these ulcers can be at sites that are not usually visible, like in the mouth or in the rectum. People can also have some swollen lymph nodes around that area, but again, it's not usually very impressive. I do have a picture. So this is a picture of a chancre, or that ulcer on a penis. So it kind of looks, I think, a bit impressive, but again, it's painless, and so a lot of people may not go to the healthcare practitioner to get testing for syphilis. The second stage of syphilis is secondary syphilis, and this is usually characterized by a rash that's non-itchy, and it can be on the trunk, the palms, or the soles. People can also have much more lymph nodes that are enlarged, so around the whole body. But most of the time, people feel pretty well, and so another reason why they're not often going to the healthcare practitioner for testing or treatment. So here are some pictures of secondary syphilis. So this is a picture of that rash on the trunk. It's that non-itchy, what we call macular papular rash on the trunk. And this is a picture of a hair loss due to syphilis. So maybe not too easy to see from back there, but there's some areas where the guy's beard doesn't have a lot of hair on it. So that's the secondary syphilis on the face. The next stage of syphilis is the latent stage, and it's called latent because it's hidden, and there really are no symptoms at this time. And we divide the stage into 2 parts, early latent and late latent. Early latent is infectious, which is less than 1 year in duration, and late latent is non-infectious, and it's greater than 1 year in duration. As I mentioned before, there's really no symptoms, and so the only way to detect syphilis in the early latent stage or the latent stages is through syphilis screening. The last stage of syphilis is tertiary syphilis, which is basically complications due to syphilis. And like I mentioned before, about a third of people who are not treated for syphilis will develop tertiary syphilis. The 2 that we routinely monitor for is cardiovascular syphilis and neurosyphilis. So cardiovascular syphilis being syphilis in the cardiovascular system, like the aorta or the heart, and neurosyphilis being syphilis in the central nervous system, like the brain or the nerves, including the nerves to the eye. And so it can cause things like blindness, dementia, and paralysis. So how can we prevent syphilis? So this is kind of most of the work that we do right now. And the first thing I wanted to mention is that syphilis, we have to think about the context in which syphilis infections are occurring. And so this is a framework that Troy and I developed together when we put together our response plan to the increase in syphilis last year. And what I really wanted to highlight is that there are a lot of factors that are involved and drive the syphilis epidemic. Some things like substance use, so like use of drugs, particularly around the times of sex, either to enhance sex or to just kind of maybe reduce people's judgment around the times of having sex. So those we know are important cofactors that may lead to syphilis infection. But the other one I wanted to highlight was the role of stigma and the stigma around STIs and STI testing and treatment that can also continue to drive syphilis by preventing people from getting the care that they need. And so I just wanted to highlight that it's not just about the infection, but there are really a large number of factors that are at play when we're thinking about syphilis infections. So on a more kind of personal level, or a more individual level, in public health, we're not very inventive, so we use the same thing, primary, secondary, and tertiary. But we do divide prevention into those three categories. So primary prevention refers to preventing infection in the first place. And so I've listed some examples of this. So the first is barrier methods or using condoms. But condoms actually are not 100% effective for syphilis. So for example, if the ulcer is outside of the area that's covered by a condom, then there's really no protection against syphilis with a condom. The second is the second example I listed here is doxycycline prophylaxis. So this is some research study that Troy and I are trying to get off the ground, looking at using daily doxycycline, which is an antibiotic, to try to prevent people from having syphilis. Secondary prevention is diagnosing the infection early. And this is really where screening and being aware of what symptoms of syphilis is in order to get timely care for timely health care. And so the recommendations for people living with HIV is to get screened for syphilis every 3 months. The third example I listed here was party notification services, and this is really a hallmark of public health intervention to prevent syphilis and to prevent transmission of syphilis. And I'll talk more about that later, so I'll just kind of mention it right here. And the third type of prevention is tertiary prevention, which is essentially preventing complications of syphilis. And really to accomplish this, we need to get people treatment for syphilis. And so being able to ensure that people get their appropriate and timely treatment of syphilis is how we can try to prevent syphilis on a tertiary level. So I mentioned party notification referral services. This is kind of our fancy name of really just talking about the process of identifying partners of recently diagnosed individuals to notify them that they may have been exposed to an STI and to refer them for STI testing and or treatment. This is a completely voluntary activity. So in other words, you don't have to disclose who your partners are if you recently had a STI. And it's done as anonymously as possible. And this can be done by a person who had been recently infected, the testing provider, the diagnosing provider, or public health can do it on an individual's behalf. But what's really important is to do this quickly, soon after the person who was first diagnosed with syphilis, so that we prevent transmission to other people, including back to the individual who was originally diagnosed with the infection. So because this is such an important piece of the public health management of syphilis, we did look at evaluating party notification in BC. So this was a random sample of 350 gay guys who was diagnosed with syphilis from 2010 to 2012. And we looked at how we were doing at each step along the way. And so of those 350 guys reported having almost 2,000 partners together. And of which about 60% of them were notifiable. And notifiable means that we had enough information to actually contact that individual. And of those 1,131 people who were notifiable, about 83% of them were notified. And of those who were notified, about a third of them were known to be tested for syphilis. And so this drop is quite significant, and this is actually one of the areas that we're really trying to see how we can do better, and in trying to make sure that people who when we tell people that they have been potentially exposed to syphilis, that they go on to get testing, because I think that's the next most important step. The last two just represents how many people of those got diagnosed with syphilis, and then how many of those got treated. And so one of the things that Troy and I are very proud about is that 100% of people who get diagnosed with syphilis through the party notification services are treated appropriately for syphilis. And in that way, we know that we're actually doing a good job preventing complications from syphilis. So some of the other things that we found out from that evaluation is that more partners get tested when they're informed by a healthcare provider versus compared to the client. But more partners are diagnosed when they're informed by the clients compared to the healthcare providers. So that tells us that the yield is actually much greater when the clients tell their partners rather than when a healthcare provider does. And so another thing that we're trying to do is seeing how we can optimize these two areas, because I think they're both important to make sure that we can reduce and prevent syphilis in the communities. So that's the end of kind of my half of the presentation. I'm just going to leave it, transfer down to Troy now for to have some discussion on HPV.
It is treacherous back here. All right. So I'm going to chat a little bit about HPV, human papillomavirus. And I apologize to those people. I know a few of you were at my talk at St. Paul's last week. I'm starting to feel like a bit of a one-trick pony because I've been doing this talk or similar talks a lot lately. So I apologize. There's going to be some repetition, but I've tailored it for the crowd, I think. So we'll get started. And it's a bit of a shifting gear. So I'm going to be talking about HPV, which is not a reportable STI, but which has implications for the health of everyone, but the health of men, and particularly men living with HIV. So I'm just going to talk a little bit about a bit of background here. So HPV is the most common viral STI worldwide, and it's responsible for a number of different health manifestations. So what most people are most familiar with would probably be genital warts, but in fact any wart you get on your body is due to HPV. And some of these warts can occur anywhere. Some of them can occur in the genital area or other parts of the body. Realistically, warts, although they're a nuisance and they're annoying, really aren't dangerous. The thing we really worry about with HPV is its potential to cause cancer. So we know that in women, for instance, basically all cervical cancers in women are caused by HPV. In anyone, men and women, over 80% of anal cancers are caused by HPV. And as a sort of an emerging area of concern is this area of head and neck cancer. So depending on where in the head and neck the cancer is occurring, 40 to 90% of head and neck cancers are due to HPV. And you can see that front page of the New York Post there with Michael Douglas. You may recall a few years ago, Michael Douglas was diagnosed with throat cancer, and he made a very strong point in the media of indicating that it wasn't because of the drinking or the smoking, it was from sex. Because apparently his tumor was found to contain HPV. I don't know if this was actually true, but that's the story he spun. Bit of anatomy for you guys tonight. A little cartoon of the anal canal here. And really you can see where we're really interested in is the area. So if you see at the bottom here, so right here, this is the outside, and then this is going into the bum here. So you have the anus here, and then an area between the anus and the rectum, which is up here. And really it's this area, this small area here, that we're interested in, and that's really where a lot of the problems from HPV and a lot of the issues with anal cancers and anal precancers occur. Just want to talk a little bit as well about the link between HPV and HIV. So this graph and this slide is really demonstrating what the rates of anal cancer have done in the last several decades, really. So, and the point to be made here is you can see that overall, all of these lines represent different populations, and you can see that overall, in general, it looks like that rates of anal cancer are increasing in all populations. And if you look at the bottom here, the bottom two lines, so the red and the blue line, you can see that that's the general population. So that's men and women, and the women are in red. So you can see that in the general population, women actually outnumber men for anal cancer rates. But when you go to the blue line at the top here, that's HIV positive MSN. So HIV positive gay men are the highest, are at the highest risk for anal cancer. And you can see that the number has continued to increase even from, so we're 1992 to 96 right here. So as many of you probably know, combination antiretroviral therapy, or the cocktails, the very effective therapies for HIV that were developed, kind of came onto the scene in the mid-90s. So despite that, despite very effective antiretroviral therapy, people doing very well, and many of the illnesses have decreased, we're still seeing an increase overall in cancer, despite very effective therapies and people doing very, very well with their health otherwise. So that's one of the sort of motivating factors for making anal cancer really a priority for everyone, but also really for men living with HIV. So just to put some of these rates into perspective, I don't want to jump into too many numbers here, but in the general population, the rates of anal cancer are not super high, 1 to 2 per 100,000. But if you're a gay man who's HIV negative, that jumps up to 40. So it jumps up basically about 20-fold. And if you're HIV positive, it jumps up about 50-fold. So if you're HIV positive and you're a gay man, your risk of anal cancer is about 50 to 100 times higher than the general population. And to put that into some context, we have this, in most parts of the developed world at least, we have very good programs for cervical cancer screening, right? So women get Pap tests every so often on a very regular schedule. There are organized, funded programs to look at these issues. And the rates of cervical cancer prior to the adoption of those screening methods were actually lower than what they are on this slide. So that just tells you how significant a problem this is potentially. So, this is a very simplified way of how anal cancer happens. So you have sex, that's the requirement typically. You get infected with a high-risk type of HPV. So not a wart-causing type, but one of the cancer-causing types. So a high-risk type, they're called high-risk or low-risk types. But that's still not enough. So most people, in anyone who gets infected with HPV, most people are going to clear it, so it's going to go away. But in order for it to cause any issues relating to cancer and precancers, you need to develop what's called a persistent infection. And only about 10% of people who become infected with HPV will develop a persistent infection. But that's a requirement, again, for the development of changes that are significant. And then once you develop a persistent infection, the HPV can cause changes in the cells and the tissues that could be, low-grade changes, which are abnormalities which aren't too bad, to high-grade changes, which are considered typically what we would call pre-cancer when we're screening people. And really the areas, so there's a couple of areas where we can, focus our attention in terms of screening and treatment. So here, infection with high-risk HPV infection. So we could screen for HPV infection, looking for the virus itself, or we can screen for changes as well, which is basically what's done with a Pap smear, which typically happens in women, but you can also do a Pap smear. All a Pap smear means is you're collecting cells and you're looking at them, so doing a swab, basically. So if you do an anal swab, you just put it, it's really just a long Q-tip. You put it in the bum, you move it around, then you send it to the lab. They'll have a look at what the cells look like in that area, and they can say, yeah, they don't look normal. They look abnormal, and they're either low grade or high grade. So that's where you would focus. You could focus your attention on screening. You could also certainly screen and find high grade changes as well. And then the other thing to think about is treatment. So you can treat typically. So I work at the anal cancer screening clinic at St. Paul's. And typically the treatment that we do is only in people who have high-grade changes. Low-grade and normal and other sort of more minor abnormalities, we don't typically offer treatment because there's not good evidence to do that. So I've already spoken about a few of these things, but how do we screen and treat for anal cancer? So it's difficult, first of all, because there's only one clinic in the province. There's only 5 or 6 clinics in the country, and there's only 12 people trained to do all of these techniques in the country. So there's 4 or 5 of us in Vancouver, and then a handful across other big centers in the country. So the waiting list, as you can imagine, some of you may have had experience with this, the waiting list at St. Paul's for non-urgent screening is huge. It's 2 to 3 years. Yeah, nothing we can do about it, it's just clinic space. So the ways we can screen and treat include Pap smears, which I've already talked about, anal HPV detection, so testing for HPV infection. That is not routinely available. It's not a great test on its own, and it's very expensive, so we don't typically use it. high-resolution anoscopy, which is what we do in our clinic, which is basically putting a little tube in the bum and magnifying that area and having a look and doing biopsies. And really doing biopsies of the areas that look suspicious is sort of the gold standard we have for diagnosing changes. I'll talk about vaccine a little bit in a couple of slides. It's my last part. Really, there's two main issues with all of this. So first of all, there's not a lot of, it hasn't been a really hot area for research. So there's been a lot of research, but not enough. And so the answer to many of these questions, so, do we even need to screen? What is the appropriate interval of screening? Like, how often do we have to see people? Who do we have to screen? All of those questions don't have good answers from the literature. And certainly even the more complicated questions, like, do we need to treat? If someone has high-grade changes from HPV, is treating that area even beneficial? Does it prevent anything bad from happening? We actually don't have data to show that it does. We do it, but we don't have data to show that it actually makes a difference. We just do it because it seems to make sense. And in women, the analogous stuff that happens, we treat them as well. So the other big issue, as I just mentioned, is that there are very few of us and very few clinics around to do this work. So before rolling out a big program, you'd really want to know whether or not someone would be willing to accept it and to engage with it and to do it. So one of the questions is, would an organized rollout of a large screening program really be acceptable to people? Would people be interested in it? And some of our work showed that it would be. So some of the literature out there shows that in areas where free anal cancer screening is available, most gay men would accept it. However, in that same area, most hadn't had it done. The other thing is the best approach to get people in for screening is unclear. So in Ontario, we have an agency called Cancer Care Ontario, which sends out mail-outs for various types of screening for cancers. So they'll send out, they'll spend millions of dollars per year on postage, and they'll get, maybe 5% response rate for various types of cancer. So that's not great. In fact, that's quite terrible. So our question was, if we're only going to get 5% of people interested, what's the point? So we did a little study in Toronto where we took a bit of a different approach. So instead of sending it from this nameless organization, we paired up with primary care providers who did a lot of HIV work. And we sent letters to patients coming from the primary care provider to see we looked at a number of things in the study, but one of the things we wanted to see was how interested people would be in anal cancer screening. So we sent out just over 1,700 invitations, and we got 56% response. So 56% of the respondents came in and actually had anal cytologies or a pap smear done. So that was great, actually. Compared to 5%, that's great. So we were happy with this. So it seems that, yes, people would be interested in this if it was offered. And, if they recognized that it was a healthcare concern that was of importance to them. The other big issue is the accuracy of and precision of our screening. And really, the bottom line with this is that, first of all, again, because there are so few clinics available and so few people doing this work, it wouldn't be appropriate to just tell everyone out there, hey, do pap smears in everyone, because then we get this huge number of results, some of which we would have to address semi-urgently, and there just would be no capacity to see everyone. The other problem is that the pap smear, not only pap smear, but HPV testing, all of those things are not very accurate tests to help predict who actually needs more urgent intervention. So let's say you did a pap and you said, okay, I'm only going to send those people who have high-grade changes to the specialist, to anoscopy. Then you would be missing some people who didn't have a high-grade pap, but some people who actually have high-grade disease, because the pap wouldn't necessarily pick up everyone. But then you said, okay, fine, I'll take anyone who doesn't have a normal pap. So high-grade, low-grade, and then indeterminate. We'll take everyone and we'll send everyone for high-resolution anoscopy. Then you would be overseeing people. So you'd be bringing too many people in and over-treating. So it's a bit of a balancing act. So we need to figure out, and I don't have the answer, but we need to figure out what the best approach is to getting people in for further care. given the resource limitations as well as the inaccuracy of our sort of screening tools. All right, a couple of minutes left, and I promise I only have a couple of minutes of slides left. So the other question that comes up is there a treatment benefit? So, we see someone who has a high-grade PAP, we go in there, we look around, take a biopsy, yes, we found the spot, high-grade disease, this is a precancer, what are we going to do about it? So in most clinics in Canada, we treat people. So we use a laser, or it's called ablation. So we use a laser or, superficial burning of the area, we get rid of that precancer, we get rid of the area that's abnormal. And then we see people back, we follow up, and we follow that area. That specific area we treated, we keep an eye on it over time to make sure it doesn't recur, because that's a possibility. So there was a study in Australia with the very appropriate name of SPANK, the Study for the Prevention of Anal Cancer. And what they did very similar stuff to what we do here. So this is fully recruited now, just over 600 patients, all gay men. 1/3 of them were HIV positive, 2/3 were not. And what they did was very similar to what we do in our clinics. So, anal pap smears, high-resolution anoscopy, biopsies when necessary. Also, they did some HPV testing, which is unusual. They usually just do that in research settings. The thing they didn't do was treatment. So they didn't treat anyone. If you had high-grade disease, if you had a precancer, they didn't treat you. They just monitored you. They saw you every 6 months. And you may be wondering, okay, how did they do that? How did they do that? And the answer is, we don't have any evidence that treating actually does anything. So they actually were very easily able to do this ethically, because there's no evidence of benefit. And the treatment is not necessarily, it's pretty straightforward, but it's not benign. And you are burning an area inside the anal canal, and it can be, it's a bit invasive. So what they wanted to do here is just to see how people did without treatment. They followed them. And reassuringly, I won't go through all of this data, but the bottom line is that without treatment, and regardless of HIV status, so whether they were HIV positive or HIV negative, about 40% of people who had high-grade lesions actually cleared them without any intervention. There were a couple of methodologic problems with the study, which I won't get into, but what does that mean? If you don't treat these high-grade lesions, many of them will actually go away on their own. Is that really what this is saying? It seems to be. So it does require further looking, but it just adds to the confusion about what to do in these cases. Finally, my last part, I just want to talk about vaccine, because this is really the part that I get asked about the most, I think. And so there's 2 vaccines currently available that are used in men. There's Gardasil and Gardasil 9. So Gardasil, run-of-the-mill Gardasil, has 4 types in it, 6 and 11, which are responsible for 90% of genital warts, so the non-dangerous types, and then 16 and 18, which are responsible for the vast majority of cancers. Gardasil 9 has added 5 additional cancer-causing types, so 31, 33, 45, 52, 58. And these are the 2 that are currently available. And we really don't have a lot of evidence for the use of Gardasil in males in general, in older males in particular, and especially in HIV-positive men. There's a few studies that have been done in HIV-positive men, so we know a couple of things. It's safe, it's immunogenic, so the response to the antibody development and the response and the protection is good, so just as good as anyone else, really. So there doesn't seem to be a problem in mounting an immune response to the vaccine. It works perfectly well. And also it seems to be very long-term, so they've rechecked people a few years later, and they seem to still have good protection. What we don't know is, should it be used in older men? And by older, I mean older than 26, so most of us are older men. Because that's really who it's approved for. And the other question is it of any benefit in someone who's already been exposed to HPV? We don't really know the answer to those questions very well. What I tend to recommend to people in general is, I typically recommend to the men who even come to our clinic, regardless of their age, that I think it's a good idea. And my tagline is, it might benefit you, it won't hurt you. If you have coverage, get it. That's kind of what I say. It's expensive, so for most people it's out of reach. It's about 150 or more per dose, and it's 3 doses over 6 months. So I certainly wouldn't push it on anyone who fell into the category who already had HPV and who is older, i.e. older than 26. I wouldn't push it on them, but I would say, if you're able to get it, get it. It might not help you, but it won't hurt you. Because I think there's still a few unanswered questions about it, and I think the potential for it to be at least somewhat protective, because there are so many different types of HPV in it, is there. So I think for those reasons, and we could have a much more comprehensive discussion about this, but for the sake of time, I won't get into it. I think in general, it's something to consider, but just chat with your physician about it is typically what I would tell people if they're unsure or struggling with how to get it covered.
Thank you very much, Dr. Brennan and Dr. Wong. That was very interesting. At this time, I'm going to turn it over quickly to Adam Rudman from our office. He's going to talk a little bit about the syphilis study, or the syphilis project that we're working on. And then after that, I will have one more announcement. We'll open for some questions.
Thank you. So one of the great things about our friends at the BC CDC and at Vancouver Coastal is that when they need to get information like this to community, they come to community. They come to organizations like Positive Living BC. So early in 2015, Vancouver Coastal approached us about facilitating a public campaign about the syphilis outbreak. But by the time the project got underway in around July, the scope of the project had expanded to include all MSM, not just POS guys. So therefore, we ourselves took a really broad community-wide approach, and we engaged our community partners like HIM and YouthCo, and of course BCCEDC and Vancouver Coastal Health, to design the campaign that you see running in front of you. The images that you see really and honestly are the result of a lot of market research and focus group testing. We did a lot of consultation within the MSM community in the Vancouver Coastal Health region, and what you see before them comes directly from their brains and mouths. What we presented originally was something that looked completely different, but we think because of the research that we did that this is going to have some impact hopefully on the community and the outbreak. Syphilis on the Rise is essentially an image-based campaign, and we've spread variations of these images, i.e. posters, stickers, club cards, postcards, bus shelter ads, transit ads around the city. Hopefully you've seen some of them so far. If you live on the Davie Street village, you probably have seen the bus shelter ads that we've had up. We've had a lot of good feedback about those. Future plans for the campaign are unclear at this point, but considering the data, I would imagine that the second phase of this campaign is something that you'll be seeing rolling out in the next year or so. Also, I should tell you that this is a completely volunteer-based campaign, so there's a lot of volunteers, including in terms of distribution. It's all volunteer. Many of you know John Kozachenko, so if you're seeing these posters and things around town, it's all because of John. But we're also relying on you, so if you are able, we left a number of the syphilis stickers on the table back there and a number of the club cards and postcards, and if you're able to take a whack and distribute them among your friends and the places where you think they'd be relevant, we'd really appreciate that help. And I think I'm going to turn the mic back over to Brandon so we can get into the question phase. Thank you.
Okay, as I turn it over to the question phase, I just wanted to let everyone know that there's a microphone at the back of the room. If you have questions, please stand up and line up there. It's going to be easier for us to hear you. The presenters, do you guys want to come up here and field questions? So the presenters can answer your questions. After that, I'll make a couple of closing remarks. We have some literature on the back table. Please have a look and take care of that and take anything that you like. And with that, I will pass it over to Dr. Brennan. You guys can, we'll start with the first question.
Hi, thank you very much for that. That was actually an amazing presentation. I learned a lot from that, and it was a way of introduction. I'm with Positive Living BC. I'm the vice chair, and I actually am survivable of anal cancer, HPV-related anal cancer. So I have a lot to say about that. I thought, even I learned a lot from that presentation. So thank you. Yeah, on the one hand, I'm also chair of our Positive Action Standing Committee, and we're looking at why the HPV vaccination is not available to and you've sort of talked about it a little bit on that we don't have the evidence right now, but I'm of the frame of mind that, this is the kind of thing, and I guess maybe I'm biased by my experience in this, but this is the kind of thing that should be available to all people that are HIV positive at the very least, because of the high rates of anal cancer amongst HIV positive people. So I'd like to hear some comments on that. The other thing I'd like to ask is that whether or not the HPV vaccination is beneficial for someone like me that has actually gone through anal cancer. And if you have any, I've heard from my doctor that it might be, and I've heard from other people that it's not, and whether or not that will be covered too.
All right, so I'll set the scene, I guess. In BC, HPV vaccination for males is covered in a select group. So ages 9 to 26, and males aged 9 to 26 who fall into one of the following categories. So HIV positive, gay or bi or questioning, those who are involved in corrections, those who are street involved, and those who are involved in the Ministry of Child and Family Development. Those groups have been identified as the highest risk, and for reasons which I was not anywhere near those tables, where the decisions were made, it was made that it would be a targeted program versus a school-based program, which is typically what exists in most provinces for females, and in a few provinces, I think 4 or 5 now, for boys. So a school-based program with the idea being that you get people vaccinated before they've had sex, so that that it's a prevention vaccine. And its indication when you read the actual product monograph is prevention. So give it to someone before they're exposed. That's really the idea. There's a lot of questions around what the vaccine can do in people who fall out of that age group. So it's not going to be publicly covered. It might be covered by private insurance. That's really people's only recourse, other than these special programs that might occasionally. So last year, Vancouver Coastal Health had some additional funding at the end of the year, and they were able to put money into HPV vaccination, specifically for MSM, so for gay men, regardless of age, and that was free. So that's, these things, but that's not sustainable. That's not something that's, going to be funded permanently. I don't know what's going to happen. That's over now. I don't know if there'll be more money coming. In terms of the benefits of HPV vaccine in others who fall inside of that group, there's a little bit of evidence from some studies that show that, I'll just give you an example, in people who have high-grade changes from HPV and who have those treated with ablation, there's always a chance, as I mentioned in my presentation, there's always a chance of recurrence. So we treat people, we follow them over time, and at the 3-year mark after treatment, up to 60% of people can have recurrence of these precancers. So there was a study that was done where they looked back. So the study wasn't designed to look at this question, but when they looked back at it and did some analyses retrospectively, they found that those who'd been vaccinated had about a 50% reduction, or were 50% less likely to develop recurrence of these precancers if they'd been vaccinated. So it seemed to be protective, but it's retrospective, and there's some issues with interpreting that. So that's one thing. And that's part of the justification I use in telling people you should get it if you can get it. The other thing is, I was involved in a study in Toronto where we looked at just what types of HPV people had, and when we looked, and it was a very sexually experienced group of gay men, a mix of HIV positive and HIV negative men. And when we looked at what types of HPV they had, because we were able to see what types they were infected with, none of them had all vaccine types, which says to me that, you know, there's a potential for protection if they don't have all vaccine types. At least, you know, they might have 2, but they don't have all 9, right? So there's a potential there for protection. Because we also know that natural infection, if you've had HPV in the past of a certain type, you might not be protected from that type later on if you've cleared it. Whereas with the vaccine, we think that there's a very sustained protection. So in general, I recommend it for, I'm biased as well, like you are. I recommend it for everyone if they can find a way to get it.
Thank you.
I was wondering, like, are there certain types of sexual practices where people would be more susceptible to syphilis? Are they kind of looking at certain sexual practices related to syphilis?
Do you mean like, do you mean sexual activities in terms of?
No, I mean, like, is anal sex, would that be a bit of a higher risk for syphilis rather than oral sex? Are they looking, when people present with syphilis, do they ask them what type of sexual practices they're engaged in?
Not consistently across clinics. I think, you know, syphilis can be transmitted via oral sex quite easily as well. So I think, you know, there's, I don't know if you could, if there's a, you know, if there's a hierarchy of sort of risk in terms of activities, because it's pretty, you know, in the grand scheme of things, syphilis is pretty easy to transmit. Because it really just needs a lesion or an area where there's organism, contact with typically mucous membrane, so mouth, penis, bum. Yeah. So I don't know if we know that there's any particular practice that is higher risk.
Okay.
There's a mic. This one, so I don't have to point it down. My question is, I think a bit more along basic science. What I'm not really understanding is what with HPV, when you talk about it clearing, what does that actually mean? When you consider that, and what does it mean to have a previous? If you previously had HPV and you clear, why is it an issue for vaccines? And so if you could just explain the processes of clearing and what it means to have a previous disease.
Can you guys stick around till the morning? So you actually hit on a very controversial, so I didn't get into it during the talk, but you actually hit on a bit of a controversial issue. So this idea of clearing, not everyone buys it. It's a bit of a controversial issue. So some people think it actually is not getting cleared, but might remain latent in the tissues. The jury is out. Some people think that's the case. Other people, for the purposes of, you know, general clinical practice, I typically just say clear it, because if you look for evidence of it in multiple different ways, you won't find it. But there's probably a role for latency, so it's probably kind of still living in the tissue somewhere, and there's a chance for reactivation. But it's really hard to tease out between reactivation and reinfection. So it's tough to know. And I mean, we don't do the typical tests that would be required to kind of get to the bottom of all that. So there's a lot of unknowns for those things. You know, we don't do blood work to see what the antibody levels are because those tests don't really exist, and they're not really super easy to get. They're most research-based. So I'm afraid I'm not going to have a very satisfactory answer for your question. But just know that the clearance thing is a bit of a controversial thing. It doesn't necessarily mean that it's completely gone. It might be still kicking around. It may never do anything, but may pop back in.
Thanks.
When I'm with someone, I'm predominantly top. Can I get HPV from them, or how does that work? Like, I won't let people inside me. You know what I mean?
Yeah, so HPV is an equal opportunity infection. So you can actually get HPV anywhere. So it's not just, so when I say it can happen, you know, you can get genital warts or you can get genital HPV, you can get it anywhere. So in addition to anal cancer, HPV is also a cause of penile cancer, and cancer is really in the genital area extending from the genitals to the anal canal. It also lives in the tissues, right? So it doesn't necessarily know anatomic boundaries. It's not going to, you know, stop at the penis. If you have penile HPV, it's not going to stop there. That's why we sometimes see, you know, people who've never had anal sex can get anal cancer as well, because it lives in the tissue. It can move around. It's very easy to spread. So even sometimes just, you know, contacts, fingers, that sort of thing can kind of move it around. So the good thing is that, you know, most people, it is a relative, even though the rates in HIV positive men are much higher than the general population, it's still a relatively uncommon cancer. The majority of people who get HPV will never develop any problems with it, the vast majority, so about 90%. It's really only those who develop persistent infections.
Thanks very much for your presentation. I was really interested in the comment or suggestion that you both are wanting to investigate or pursue prophylactic use of doxycycline for prevention of syphilis. Isn't that completely contrary to the whole thing we see, the bugs eat drugs, you know, stop using antibiotics?
Yeah. So from a public health perspective, and I mentioned this, I think, before we've had some conversations, like, I'm very happy that the Do Bugs Need Drugs campaign has made a mark and that people are being conscious about antimicrobial stewardship. So I'll maybe start with the evidence for doxycycline prophylaxis first of all. So there was a small study that was published in LA, or with this clinic in LA, that was published earlier last year, that suggested that taking doxycycline every day actually reduced syphilis, though not to a very large degree, but it did reduce it for people who were taking it. But it also reduced chlamydia and gonorrhea infections as well, which are actually much more common than syphilis. And so that's led people to think about whether or not doxycycline, for one, does it work against preventing these types of STIs. So when Troy and I were thinking about whether or not we wanted to pursue this, the thoughts in our mind is to really think about what's the risk-benefit ratio of using doxycycline prophylaxis or any type of treatment, really, or medications at all, to prevent any types of disease, including syphilis and chlamydia and gonorrhea. And I think that's really, so maybe I'll just say, so the doxycycline itself does have side effects as well. So taking a pill a day does have its own side effects, and we do have to weigh those risks and benefits every time we consider putting somebody on doxycycline prophylaxis. I think what we see is that syphilis is a big problem. Syphilis is a big problem for the community, for the population at large, and syphilis is a big problem for the individual themselves. So being a partner to somebody who recently got diagnosed with syphilis or having a diagnosis of syphilis, there's a lot of treatment that is needed to cure people of syphilis, and people can also develop complications of syphilis, which I mentioned before too. And so we do want to weigh those risks of having syphilis to the benefits of having doxycycline, as well as the risks of doxycycline to the individual in terms of side effects, and also for antimicrobial resistance as well. And I think the answer to that, like I think Troy and I have kind of said multiple times through the questioning with him, is we don't really know the answer to that. And that's one of the reasons why we want to study it. And so Troy and I put a proposal together to look at doxycycline prophylaxis, and one of the things that we are specifically looking for is whether or not we may be leading to more antimicrobial resistance. And so we do want to measure specifically, are we seeing changing patterns of antimicrobial resistance for people who are using doxycycline every single day. The last thing I'll say is, so when we think about these risk-benefit ratios, we're also thinking about, are there people that may be, or populations that may be more at risk for syphilis, that may be more likely to benefit, and may be worth that, the risk of taking those medicines. And so in our proposal, we did look at specifically HIV-positive gay men because that is where the highest rates of syphilis is occurring. And in that way, we're hoping that we can try to mitigate some of those risks that you mentioned. But I am very glad that you bring this up, and I don't want to seem like we're throwing doxycycline in the water because we think it can work. It is really a very measured and targeted approach that we're trying to pursue. Want to add?
Well, you may want to connect with your Lyme disease people because it's exactly the opposite discussion. You know, the availability of doxycycline or ketoconazole is severely restricted in that case, and you know you might find some commonalities helpful to both diseases.
Sorry, I missed, what did you say in the beginning? The commonality of doxycycline for
Lyme disease.
For Lyme disease, yeah.
And BC Center for Disease Control, Dr. Morissette particularly, has done quite a lot of work on that, so you may want to make some connections. And actually, kind of be helpful, not say this is a problem, but this is possibly an opportunity.
Mm-hmm. Yeah, Dr. Morissette's actually on our grant as well. He's had some, yeah, thanks. Good.
Thank you very much. We just have a question from on the webinar.
And our online audience wants to know, how much of the rise in syphilis do you think is due to low levels of testing and men carrying it for years? For years and years.
So I am very impressed with the level of questioning. They're very, these are really the questions that we are struggling with every single day. So I'm really happy to be able to maybe talk about some of these things. So in a nutshell, the answer maybe I don't know how much that is happening in the case. What we do know is that testing has increased substantially and continues to increase year after year. What we have less evidence for, less data about, is it the same people that are getting tested over and over again, or are there small populations of people who are just consistently not being tested for syphilis? So I think the answer to that is mixed. I think one of the reasons that we are having a rise in syphilis is because we are increasing the testing for syphilis. So in other words, because we are looking for syphilis, we are able to find more syphilis. And I think that's a good thing because we can actually get people treated for syphilis and we can actually prevent onward transmission of syphilis. When we look at something called percent positivity, which means what is the percent of all the tests that we've done that are positive for syphilis, we have seen an increase in the percent positivity from about 2010 to 2015. So I think it's increased from about 12 per 1,000 to about 32 per 1,000 if we look for HIV positive men. And so what that tells us is that even though we're testing a lot more, we're also finding a lot more cases, which suggests that in addition to people testing more often, I think there is a greater burden of syphilis that's in the community. So I think both of those pieces are at play. And one of the third thing I want to mention is when I talked about party notification and services. So the reason why this is really important is that if we only treat one individual and we don't treat their partners, what we can have is the syphilis is just going back and forth. So you treat one person, you cure that person of syphilis, the partner now has syphilis, and then they later on get treated, but they've actually already passed it on back to the initial individual. And one of the challenges of syphilis is because it takes such a long time, or they can have such a long latency period, that people can be living with syphilis for a very long time and can therefore be transferring it back and forth for a very long time. And so this is what we call asynchronous treatment of partners in the case. And that's, I think, one of the reasons why we may be considering seeing just kind of these small networks of syphilis being passed between these networks. I don't have any proof of this. It's just really kind of a real theoretical standpoint, just thinking about how syphilis is very challenging. And for that reason, I think I strongly encourage we are trying to evaluate and improve upon our party notification. But I think from an individual perspective, making sure that people are regularly screened so that we reduce the interval in which people may be living with syphilis and not aware that they have syphilis.
My name is Walter. I'm with the Positive Living of BC organization, and my question is follows based on what my doctor told me one time about a couple of years ago. I was contacted through those means in terms of I might have been exposed to the syphilis, and so I went to my doctor and was obviously going to give me shots because I thought might as well do that. So the initial test before getting the shots and the tests afterwards both showed negative. So my thing at the time was like, so I got these shots for nothing. And at the same time, I had a discussion with him later, and he also indicated that sometimes testing isn't very decisive, that some tests it's borderline whether it's positive or not, and maybe you can speak on that. It seems like some testing isn't very consistent.
So, up until July 2014, the testing for syphilis, the screening test for syphilis was something called an RPR, which wasn't a great test as a screening test. Just to give you an example, Ontario as a province switched over to a different testing mechanism in 2004. So in 2014 in BC, we switched over to a better test, which is more sensitive. So the problem with that original test was that it could appear negative because it was a non-specific test. It was a test that wasn't very specific for syphilis itself. So it could appear negative actually, even in someone who hadn't been treated, but who perhaps had been infected years ago. We now have much better testing that involves a screening test that is specific to syphilis, the organism causing syphilis, and that test, that initial screening test that's done is really when someone has the infection should be positive for life. So even if they've been treated, it should remain positive for life, and then there's a sort of a cascade of other testing that occurs to determine whether it's an old infection or a new infection. We chat with, each syphilis, positive syphilis test in this province is actually individually reviewed, personally reviewed by a physician at our center. I do it Friday mornings. And we basically personally look at each potential case and determine what stage, what treatment's needed. We speak with the physicians. We get our nurses involved in ensuring that everything gets done appropriately. So now the testing is much better and it's much more easy. It's much easier to interpret. The old testing was a bit problematic in some settings to interpret, so it would sometimes look negative when it may have been an old infection.
Thank you much. Sorry. If I could add a few more. So one of the other things about syphilis, so we have something called the transmission efficiency, and that refers to how frequently somebody, if you had contact with syphilis, you would actually get the syphilis infection. So syphilis efficiency is about 0.3, so about 30%, which is about middle of the road. So there's some that are higher and some that are lower than the transmission efficiency of syphilis. So just because you're a partner of someone who was diagnosed with syphilis doesn't automatically mean that you will get syphilis. And Troy mentioned some of the things about the testing, but the other thing about the limitations of the test is that people may, it takes a while before we see the positive blood test. So it takes about 90 days maximum to get a positive blood test for syphilis. And so if you're named as a partner, or if you're a partner to somebody who was diagnosed with syphilis within a short time frame, so 90 days, we would recommend treatment regardless of what the test showed, because the test actually may be negative even though you have the infection or about to get the infection. And so there are a lot of maybe complexities of syphilis and around the blood testing or the serology that makes it sometimes difficult to know who's going to get syphilis, who's not going to get syphilis, and the treatment, therefore, we tend to be safer rather than sorry to try to make sure that we prevent people from getting syphilis.
Hi, I guess I should identify myself since I didn't the first time. I'm Tom McCauley. I'm also on the board of directors of Positive Living BC. I think what I'm going to do here is probably make more of a statement than ask a question, but you may want to comment. It seems to me that what isn't being discussed in this discussion on the rise of syphilis infections in in our community is what I see the pathway that it's followed is HIV medications to treat the virus have become successful. With success has become the label undetectable. With the label, before even undetectable, there was bareback sex, but with undetectability, there's, I think, an even broader use of bareback sex as a reality amongst gay men. And it seems to me that it's pretty obvious that the more bareback sex there is in the community, the more risk and the more risk for increase of infection amongst the population that's barebacking.
So I think that's for sure, I think what a top hypothesis of why syphilis is increasing, and likely why it's increasing not just in our jurisdiction, but basically every developed country in the world, and particularly around gay men. So I think what you mentioned is likely true. Again, I don't have proof that it's happening because that's not really the level of the questions that we ask from a surveillance standpoint. But I think that's really why I want to go back to that kind of large diagram that I showed about the context. So that piece around what we call seroadaptive behaviors, or condomless sex for people choosing people who have the same HIV status as themselves, is potentially and maybe even likely one of the drivers of syphilis. So the way that we approach that is, so now that first is, do we know that that's happening? But I think there's more and more evidence that likely this is happening, and I think hearing from a community member that it is happening definitely is one of those proof that I think is very helpful. So what then do we do about it? And to me, I think the approach that we need to take is what we would call a syndemics approach. In other words, we need to think about not just syphilis, not just HIV. We really need to think about this together, and we need to think about this as what are the different tools that we have in our toolbox to try to actually prevent syphilis. And so even though I think condoms was a mainstay for STI prevention and even pregnancy prevention for many, many years, we do recognize that the interest for using condoms is also waning. That being said, there's a lot of studies that show that maintaining the same level of condom use on a population level is a goal that can be achieved and has been achieved in many jurisdictions. So that's one area that we could continue to work on. But that's one of the reasons why Troy and I are interested in other forms of primary prevention like doxycycline prophylaxis. So even though there was risks, and I think I'm really glad that you brought those risks up, these are some of the realities that I think we need to grapple with and need to really think more innovatively about how can we address STIs, including syphilis, including HPV, and including HIV.
Thank you.
I just want to comment on the last comment. While I do bareback, I just want to point out that one of the risks that I see when attempting to bareback with someone is that many, not all, but many people whom I try to contact with are high, doing PNP, or whatever the case may be. And that certainly is one of the risks as well. It's not a debate, and I don't expect doctors to solve that issue either. But I don't want to be associated as a person who barebacks as someone who's highly at risk when I see perhaps other people who constantly party, do drugs, all of these types of things, who are more at risk at getting HPV or syphilis or anything like this. Because on a personal level, I'm kind of glad at this point I live in Westminster, because my attempts to contact someone here in Vancouver is futile. Because one, nobody wants to travel out there. Two, they're either high on drugs, that kind of thing. And I expressly state I don't want drugs. And it's that type of thing. So this is where sociology comes in. This is where psychology comes in. This is where all these other ologies come in. and doctors deal with what you deal with. There's more to it than just people who bareback. There's a lot more to it.
Yeah, and I'll just, you bring up a great point. I think Jason did, in Jason's last comment, he did mention this idea of syndemics, and just to get into a bit more detail about that, that really does encompass all of these other things. So that big, messy, I can call it messy because I came up with the original idea, it was in my thesis. So it was a mess of things that were up there. That really does incorporate all of those things. So, mental health issues, drug use, substance use. And I think, one of the things we're doing as well, so we talked about this doxycycline project that we're doing, but we're also now funded by the Vancouver Foundation to do a qualitative study, really coming to the community. It's a participatory action research project, coming to the community and speaking, doing qualitative interviews with the community and asking them these questions. What's happening out there? And to really try to get an understanding of why rates of certain STIs are going up, and what people think when they engage in sex, and really just to get a feel for the community. And we think that the answers, of which we currently don't have many of, we think, we're hopeful that a lot of answers will come from these sort of forays into the community and asking them questions about what's going on.
And I'll mention that Positive Living is a partner for that study.
Right.
So this is a two-parter. It's a statement and a couple of questions. I imagine, given time, this will probably be our last.
Yeah, we're near the end.
We'll see it then. So bear with me because the screen is a bit difficult to read here. I have seen data on HIV testing, comparing the estimated adult gay male population to the actual number of HIV tests performed over 5 years in Ontario. Only about 20% of gay men were tested per year. A similar comparison was also done in the UK with the same results. If our HIV testing rates are that low, and we know that testing for other STIs is lower, is it likely that there is an extremely high pool of undiagnosed syphilis in the gay male population? Why don't we deal with that one first, and then I'll give you the second part.
Sure. Yeah, so I'll start with saying, this is on?
Yeah.
Okay, so that we really don't know what the gay men's population is in the Lower Mainland. There's been a lot of attempts to try to estimate that so that we can come up with some of these figures that this individual is making reference to. I do want to highlight that there are a few differences between our jurisdiction and other jurisdictions like Ontario and the UK, and namely it's the Stop HIV program. And so the Stop HIV program was piloted in 2009 and was officially launched as a provincial program in 2012. And when we look at our testing data, we do see what we call like a hockey stick method. So it looks like this before 2010, and then it looks like this after 2010. And we see that for that. So those are our testing rates for HIV, hepatitis C, as well as syphilis. And so I do recognize that this individual is mentioning a problem that is very likely, like that there is some people who are reluctant or prefer not to, or can't find a clinic that kind of meets their needs, and so it's not getting tested as regularly as they could be. And so I do recognize that that is a gap, and that is something that we are trying to address. So one example is, so we do have something called Get Checked Online, which allows people to get testing using an online platform. Basically, they can print off a requisition online and go to one of a few Life Labs locations and get their testing done. So we do recognize that that is a gap that we do need to address. But if we look kind of on the whole, given that those increases are occurring in HIV, syphilis, and hepatitis C testing, it does give me hope that that we are normalizing these types of testing behaviors, and hopefully encouraging actually the greater population to know their HIV status, to know their syphilis status, to actually prevent onward transmission for these types of infections.
In the era of PrEP, do you think that the high testing rates for PrEPsters and partner notification, it may actually reduce the pool of undiagnosed syphilis and other STIs in our population?
So you said whether or not the era of HIV PrEP may reduce the era of...
May reduce the rates of
reduce-
undiagnosed.
Yeah, I think what he's implying is that in the era of PrEP, that there is increased testing among PrEPsters. Do you think that that will decrease the pool of syphilis and other STIs in gay male population?
That's a really good question. I don't know. I think there are reasons for both. So usually people who are on HIV PrEP get testing for at least HIV, but usually all STIs on a more regular basis. And so with that in mind, there is a high likelihood that individuals would get diagnosed or get diagnosed earlier in their course of infection. But on the flip side, we do know that people who are choosing to take HIV PrEP usually are engaged in higher risk sexual behaviors, and which is usually the reason why they are on PrEP in the first place. And so we do know that there is some baseline elevated risk for STI, but what we don't see is an increase in that risk when people start on HIV PrEP. So I think the two lines may be blurred. So if we think about somebody who was on HIV PrEP versus not on HIV PrEP, but the same individual, could they potentially be tested more and diagnosed earlier? I think very likely, because they are getting more regular screening. But I also think that people who are taking HIV PrEP tend to be a more engaged individual in the first place, and so they probably do tend to have more testing rather than somebody who is less engaged. So I think it is a bit of a complicated question. I don't have the answer to that, and I think we will have to study to find the answers.
Yeah, and just to add to that, I think it all depends on how much testing was happening before they went on PrEP, for instance, because just to echo some of what Jason said, when you look at the actual trials that were done and the studies that were done on HIV PrEP, and you look at, they've always looked at they almost always look at this idea of what's called risk compensation, which means basically does PrEP lead to riskier behavior? And they consistently have not found evidence of risk compensation in these studies. Some people think that's not true. Some people think it actually does happen. Anecdotally, they see these patients and they hear about it. But the other point that Jason made, which is a good one, is that often the people who opt to take PrEP are people who are already engaging in what would be considered higher risk behavior. So it's not causing higher risk behavior, it's just protecting people who are already engaging in high risk behavior. And then the other issue is, again, in these studies, we haven't seen a consistent increase in STI rates, though the rates are typically higher than they would normally be in let's say, the general population. Yeah, it's a tough question to answer. I hope our convoluted way of answering it was okay. But.
Thank you very much. Before we go, I didn't get to ask my question. Actually, somebody else asked one of the questions I had. But I just was curious, Dr. Brennan, what you talked about, there's really a very limited amount of resources for people doing HPV work and lab work, and doctors who do that dysplasia work. What is the future of that? Is there kind of any indication that that's going to grow?
Hopefully, would be my answer. I'm actively trying. I also have, before I left, I told many of you that I moved here about a year ago from Toronto. I was in Toronto before this. And prior to moving, I was part of this, I'm still part of this very large CIHR-funded team grant. Many of you know about it, or some of you know about it at least, and are involved. Looking at basically many of the unanswered questions for the care of and management of HPV and HPV-associated stuff in gay men, specifically HIV-positive gay men. So we recognize that there's a lot of unanswered questions, which I went over a few of them tonight, and we developed this research program trying to answer many of those questions. It's a funded study. I'm really trying to bring some of it here. A lot of it is happening in Toronto right now, but I really was hoping to open up here, but that's really reliant on having additional clinic time and clinic space. So I'm actively working on that now. Like I said, you know, the wait times not only in our clinic, but in many clinics across the world that do this work, because there are so few of them, are inappropriately long. So I'm hopeful and crossing my fingers. That's all I can say.
All right, thank you very much. So I think that's all the time that we have for tonight. Before we go, I would really like to thank Dr. Brennan and Dr. Wong, and also Adam Ryman from our office for the presentations. It was incredibly enlightening. I found it really fascinating, everything that you had to say. I want to thank our pharmaceutical sponsor, that is Vive Shire tonight. Thank you very much for your generous support. I want to thank the Chateau Granville for this terrific meal and this great space where we had this opportunity to meet tonight. On behalf of Positive Living BC, I would like to thank everyone who came. So again, there's some literature on the table if you want to have a quick look. I wanted just to remind everyone that at our next event, I just want to remind everyone to RSVP because it really helps me do proper counts. A few people came tonight that weren't on my list, which you're totally welcome to come, but it just will help me to plan this if you can just RSVP as much as possible. Thank you again, and that's it for tonight.